is Dr. Evan Osar, author of Corrective Exercise Solutions to Common Hip and Shoulder Dysfunction. We get a lot of questions about this deadlift and squat. And again, when I refer to the deadlift and squat, I'm looking at control. I am not talking about if you're dealing with athletes. I'm not talking about if you're dealing with muscle heads. I'm not talking about power lifters. I'm talking about if you're training in the general population, you need to adhere to specific cues, and you cannot use the cues that these guys are using with professional athletes and power lifters and these hardcore people, because you will destroy your clients' spines. And let me show you what I'm talking about with that. I should say spine and hip, by doing a lot of the cues that many in the industry perpetuate. Because if you're not looking for control, then you're actually creating dysfunction. Let me show you some common areas of dysfunction in the deadlift. So I'm going to have Stephen use this light bar, and you're like, why is he using a light bar? Because he's going to jack his back and hips up doing this pattern, so I got to take care of my boy as he's going through these patterns. So again, he's going to show you the common thing that we teach clients, or that gets taught in the industry. So do the pattern as a way many people teach it. So what they do is you go into your deadlift, and again, he's got real nice control here, so everything looks good here, and then come up and drive forward. And you see the clients just drive their hips forward, and we teach clients to go into massive hip extension. But if I actually palpate, move your arms just a minute, Stephen, if you can see, his femoral head is sitting so far forward in his socket that it's creating dysfunction. Relax just for a minute. The most common hip dysfunction is when the hip goes too far anterior in the humeral, or actually in the acetabulum. You must be able to centrate during hip extension. So your hip must go like this as you go into hip extension, not drive forward in the socket. Almost all the patients I see that come in with hip dysfunction, they all have an anterior femoral head position in the acetabulum. Every single person that has a joint or needs a hip joint replacement, they have wear and tear on the anterior superior portion of the femoral head, because they grip so much with their butt, they drive the femoral head forward in the socket, and they just grind the crap out of their femoral head. So it's really important that when we teach the deadlift pattern, that we're teaching clients to come up and centrate that hip in the socket, not drive it forward. Problem number 2 is what happens at the pelvis and the lumbar spine. So again, do it again, Stephen. And again, drive so far forward into anterior extension, or I should say hyperextension of the thoracolumbar junction. So you start to overload the thoracolumbar junction, and now you start to get flexion, posterior tilting and flexion of the lumbar spine. So again, you relax, relax, relax. So again, you're getting flexion of the lumbar spine, again, under heavy loads. These clients are driving into posterior tilt and lumbar spine flexion. Again, the best thing to do if you want to herniate somebody's disc is to go into a posterior tilt and lumbar spine flexion. So again, terrible for the low back. Third thing, do one more rep, is when you go into a posterior tilt and lumbar spine flexion, you start extending through your mid-back, and then you start flexing through the upper thorax and the neck. Again, you see his spine going into spinal flexion here. Again, terrible for your cervical discs, especially at C6, C5, C6, C7, where most of the disc herniations happen. And now you get this huge load pulling down right at the segment of the spine. So again, 3 common areas that become problematic from doing a deadlift that's taught and perpetuated in our industry. Let me show you how to make this pattern better and more effective and safer for your clients. And again, we're talking about the general population, because again, those are the clients that are coming to us with the most amount of dysfunction. Stephen set up. When he comes out of his deadlift pattern, I want him to think about driving towards the ceiling, pushing the feet through the floor, keeping his core active, driving towards the ceiling, not driving that pelvis forward, just back to a neutral position, not into anterior tilt, not into a posterior tilt, just driving up towards the ceiling. He's going to keep his core active and remain throughout the pattern, and he's going to keep that head in neutral position as he drives up towards the ceiling. So again, I'll make sure he stays activated. He sits back to pre-activate the glutes and the hamstrings. He has nice, good scapular control. Go ahead, lift up. And towards the ceiling, drive up, drive up, drive up. Perfect. Nice, good core control. Come back down now. I'll have him do 2 more reps. I'm going to make sure he has core control the entire time, nice and long through his spine. Again, and he drives up. Again, good glute activation, but not driving that femoral head forward. Here's where his femoral head is here. Good. 1 more rep, Stephen. And when you do this pattern right, it becomes incredibly hard exercise. Perfect. And then drop it back down under control. He keeps good core control all the way back down to the floor. So again, the keys here, keep a neutral spine position. Get those hips moving. Come back up towards the ceiling. Stay long. Do not hyperextend the thoracolumbar junction. Do not drive that pelvis forward into a posterior pelvic tilt, and keep breathing throughout the pattern. This is Dr. Evan Osar with Fitness Education Seminars. I hope you enjoyed this video. We'll catch you next time.